Yep.
Hi, good afternoon, 12:30. Welcome to another edition, Newton-Wellesley Medical Group Lunch and Learn. I'm not quite sure why I'm screaming. Sorry about that. Today's updates, we have a great update in prostate cancer 2020. We're excited to hear this talk. And thanks for you guys for showing up. I appreciate it, Chrissy and Demi. Thanks so much. Next slide. Of course, you can put in for CME credit. The CME code is, wow, 2 Q's in one code, QACQAY. That's an interesting one. All right. Sounds like a good crossword word. But anyway, go ahead and put that in the usual way. 30 minutes of CME. Next slide. Also, just want to tease what's coming up. We have 2 good talks coming up. We have Jay Simon's going to talk to us about shoulder arthropathy next week. And then, of course, the following Thursday is Thanksgiving, whatever that's going to look like this year and for all of you. And then we'll skip that week. And then December 3rd, Dr. Ellie Tomczyk, one of our newer plastic surgeons, will be talking about breast implants. Next slide. And now I'll be quiet and hand it over to our speakers. Thank you so much.
Thanks, John. And thanks, Demi, for joining me with this. And thanks, everyone, for having us. I did not grow a mustache out for this event, but Demi has. And so Movember is Prostate Cancer Awareness Month, and so we thought it was a good topic. And start by, I know we've all seen this before, but just sort of for PCPs, I know we could spend 300 minutes, not just 30, talking about PSA screening. These are the U.S. Preventative Service Task Force recommendations. I think they're sort of loaded with kind of issues by screening men 70 and older. Do not screen 55 to 69. I know you guys heard me talk about this. Just some take-home things about screening. It's not perfect. We're going to miss some high-risk metastatic cancers in older people who are not screening, and we're going to miss some of them in younger folks. So things that I sort of think about when having these discussions, I always take, these are our NCCN guidelines. Family history, I can't stress the importance of family history. So, the guy that is 74, you wouldn't normally screen, but has 3 brothers with prostate cancer, a dad with it, tend to think of those in a higher risk category. Along the same lines, African American is the other category in addition to family history. So certainly think about screening African American male and screening them at a younger age. The family history also goes into family history in terms of risk testing, so BRCA mutations, but also several other mutations. So even if the dad didn't have prostate cancer, but there's colon, there's breast, there's ovarian, Ashkenazi Jewish, think of those people as people to screen. This is just it's a very sort of messy slide, but I think the way I think of this is, I like this quote, don't let the perfect be the enemy of the good. I think we can do and capture a lot more people if we sort of screen smarter. And what do I mean by that? Besides race and family history, take into account your age and the PSA. PSA rises as you get older. You really want to reduce the false positives. And so if you're 75 and your PSA is less than 3, that man is not going to have prostate cancer. Similarly, if you're younger and the PSA is higher, that's a higher risk. Think about your PSA density. When there's more prostate cancer cells, whether they're cancerous or not, they make more PSA. Similarly, a smaller size prostate that has a high PSA, that's more concerning. I can't stress enough repeating. So one isolated PSA in isolation, don't repeat it in a week, the 7 days of Cipro and then you repeat it in a week. Really widen the testing interval. 6 to 12 weeks is what I would say in terms of widening the testing interval. Using more specific panels, this is an area in progress, different isoforms. I'd say it's not ready for prime time. Different risk stratifications, free PSA. These are all things that are not readily available, but coming into play. think raising the abnormal PSA threshold, and along with that, looking at trends. So somebody whose PSA has been, regardless of age, 2, 3, and just staying like that, you may want to increase the interval to every 2 years, or you may feel comfortable in that person stopping at 70 or 75 if it's been stable. A lot of times we see people where they've reached a certain age and the PSA testing screening just stops. And even though there's been a trend up over the years, 1 to 1.5 to 3 to 3.5. And so these are all kind of things to think about. I know it's much more involved than that when they're sitting in your office and you have 10 other things to think about. But these are the sort of things I want to focus on for our talk, because I think this is the future of where prostate cancer is going. The big knock and a big part of the task force recommendations were we're overdiagnosing and thus overtreating. So one of the main points I want to drive home is just because you screen for PSA and they go through a biopsy does not mean that all of these men are going to get treated and the side effects with treatment. So our goal is really to promote active surveillance in the people who are appropriate with low risk cancers, but also in older men with a limited life expectancy. We have good active surveillance protocols, which I'll talk about. And so diagnosis does not equate to treatment in 2020. And then PSA screening, when you identify it, we have newer imaging and biopsy techniques that are available, both that help in diagnosis, but also helping us decide who to surveil, thus further decreasing the side effects and the potential for overtreatment. And then I think the other thing to highlight, we'll talk about multidisciplinary GU care here at Newton-Wellesley, is I don't want you to feel like you're making these decisions in isolation. While the screening part can happen in isolation in your office, I want to make sure you're aware of our availability and sort of the larger team that can be involved in making these decisions for your patients. So when we talk about active surveillance, I think it's important to know that the question is not, when I see somebody with low risk prostate cancer, treatment versus no treatment. It's not saying, okay, we found this, we're not going to treat you and that's it. To me, really the question is, are we going to treat you now, or are you going to be on an active surveillance plan? And the whole idea of active surveillance is to actively monitor the course of the disease with the idea and the expectation that you're going to intervene with curative intent if you find signs of progression. And so we've really honed in on this active surveillance protocol where patients are getting a PSA every 6 months. You're getting a DRE at least once a year, if not every time you get the PSA. And then once we've diagnosed a low-risk prostate cancer, you do another biopsy within 12 months, somewhere in that 12 to 18 months. And then you sort of do serial biopsies, depending what you find, every 2 to 5 years. And you repeat a biopsy if DRE changes, your PSA rises, or we'll talk about MRI, suggestive of more aggressive disease. I know we're going to get to MRI, but I'll highlight that MRI should not be used as a replacement for re-biopsy. So we have a lot of fancy new techniques, but if you feel a nodule in the clinic and the MRI is normal, that doesn't mean that they don't have prostate cancer. It's MRI, and we'll talk about it, is used to identify higher grade cancers or improve the detection. It is not a substitute for your exam and your prostate biopsy. So how good is active surveillance? I put this here because these are sort of the big centers that started active surveillance and have been doing it for the most time. Again, we are intervening when we see signs of the disease progressing. So we're avoiding overtreatment, but we're not observing and just letting people develop metastatic disease. So you can see the cancer-specific survival with active surveillance. Not surprising, these men have low-risk prostate cancer, so excellent cancer-specific survival. But the highlight here, I think the most important part is on active surveillance, about a third of men, so 30% upwards to 50%, are going to convert to active treatment. And this is the population we're trying to capture. You know, the 55-year-old with low risk that is going to need treatment because they're in this 30 to 50%, but may stave off side effects for months to years from treating them right away. Conversely, what we're trying to capture is that 70% or 50% are men who are never going to need treatment by this active surveillance protocol. And so screening still fraught with issues, using other parameters to help with who should continue screening and who should be referred for biopsy, and then understanding that we don't treat everybody who gets diagnosed with increased active surveillance. And so with that as sort of an introduction, I want to highlight the newer techniques we have and the multidisciplinary clinic to help in diagnosis and treatment of our prostate cancer patients. I know there'll be questions and we'll sort of take them at the end. So I'd like to introduce you to Dr. Zlatev, who is growing out a weird mustache type here, to go ahead and take over for this part.
Perfect. Thank you, Chrissy. Yes, I do have it. Here's my justification. I didn't want everybody to think that I just wear this routinely. You know, we're on Team Bellissimo this year, you know, raising awareness for prostate cancer. Of course, this for me usually lasts me probably around Thanksgiving when my wife rebels and it has to go. But next slide. The person to blame is Rick Lee, our captain seen here. And, you know, this is Rick Lee towards the end of November. So you can see he actually doesn't suffer from, I mean, he says that he does November, but, you know, there's no evidence of it really. So it's great. So that as a disclaimer, moving on to the next slide, you know, I wanted to talk about biopsy because, you know, once we started, you know, on the path of detecting prostate cancer, inevitably we need tissue to actually get that diagnosis. And, you know, prostate cancer is the only organ for which traditionally we diagnose it with a non-targeted biopsy. So, and the reason for that was that we never really had good imaging to target anything, to image anything. CT scan is basically a coin flip. I mean, it's great for kidney cancer, and other cancers, but it's absolutely terrible as far as penetrating down to the prostate. And ultrasound is only slightly better, definitely better, but only slightly. So we did this double sextant biopsy where we take at different levels close to the bladder and down towards the apex. And we do 6 on each side, targeting the peripheral zone where we know prostate cancer lives. Next slide. The limitations of this, however, are that we detect a lot of clinically insignificant cancer. Next. And we underdetect clinically significant cancer. With this type of biopsy, there's about a 20% false negative rate. Next. What this does is that in general, there's an undersampling and almost like an overrepresentation of low grade. And we know that there's about 40% of low grade cancer also, those prostates harbor more advanced disease. So not ideal. So can the MRI help? And the answer is yes. The MRI can certainly help. A couple of things. The keys to a good MRI are a good modern MRI with a 3 Tesla magnet. Usually we don't need a coil. And the other key thing is an experienced radiologist, somebody that reads a lot of these and has experience in not overcalling or not undercalling, because you have to look at several parameters of the MRI, specifically 4 of them. And they're over here. 3 main ones. The T2 weighted imaging. So this is a T2 shot, and you see where the arrow points that on this phase, cancer looks dark. at the periphery. The peripheral zone should be bright, but that area there is darkened. Next one. Here's a sagittal view of the same shot, and you see that dark spot. And the other type of parameter that we have, next one, is the ADC, and that's a diffusion. So basically looking at the way water molecules travel, and cancer essentially interrupts that. So as a result, you see a dark spot there as well. And finally, the contrast enhancement, there's more blood vessels in this area, so you see a little bit more take up of contrast early. So combining these parameters are used by the radiologist to classify the risk of an area in the prostate as having cancer. And we're not talking about just regular Gleason 6 or 3+4 grade group 1 cancer, 1 or 2. We're talking about 4+3 or grade group 3 and greater. So that's the clinically significant prostate cancer that can cause a person harm. And they're based on this 1 through 5 scale, where 1 and 2, if you were to biopsy a 1 or a 2, the chance of getting a return of clinically significant prostate cancer is less than 5%. So we don't typically biopsy those, but 3, 4, and 5, you can see that it increases, where a 5 is 50 to 80% that you're going to find clinically significant prostate cancer that will need treatment. So we biopsy 3, 4, and 5. Next. But how do we actually, so to summarize, basically what the MRI is doing for us from the last 5 years of research, we know that the MRI, next one, the MRI detects, significantly increases the detection of clinically significant higher risk prostate cancer. As something to remember, TRUS ultrasound will miss about 20% of these, whereas MRI only 10%. And it also lowers the detection of those lower risk cancers, the grade group 1 or low volume grade group 2. And we'll take that. Those are not the ones. Those are ideal for active surveillance, actually. So it's not that big of a deal to miss those. So how do we go from a MRI to actually doing this biopsy? Well, we have the fusion technology. It requires a software. We don't actually biopsy in the MRI suite, so the patient has already had the MRI by the time we see them, and we have this system that actually converts and is able to overlay and map the MRI images onto our ultrasound that we use for the biopsy, and it's depicted here. We have the EuroNav system down at MGH. Next slide. And what you see here is the radiologist has outlined the prostate in purple, and also the region of interest in green. That's the area of the PIRAS lesion. Next slide. And then what you do as a urologist is you create your own 3D object with the ultrasound, and then you have to align everything so that the two are aligned. And in the bottom right of the screen, if you go to next slide, you'll see that once that's aligned, it will fuse it, and you should see, quote unquote, the target on your ultrasound. Next slide. And then once that's done, then you just have to literally hit the target on the ultrasound. And that's how that's done. And you can actually freeze it every time you do a biopsy, and it'll record it on the software screen. The way that this has been done traditionally for decades, just ultrasound biopsies in general, is transrectal, meaning that you have a probe in the rectum, but the biopsy needles are also going through the rectum, right around the probe. So the side effects that we often talk about, blood in the urine, blood in the stool for a couple of days, that's fine. Blood in the semen for weeks, that's also fine and very benign. Very rarely do we see severe bleeding. But the big thing is sepsis. I mean, that's always something that is in the back of our minds. Despite antibiotics, there's a 1 to 2% risk of sepsis, which is quite significant. However, we have now started doing this transperineally. So at MGH, we're actually the first center here in the area doing this, where the probe is still in the rectum, but the needles are coming from the outside, and they're going through the skin, through the perineum. So still same minor side effects, but the sepsis rate is almost zero. And that is a huge change and a very significant advancement about these biopsies. And then finally, what I wanted to say is to also mention is that at Newton-Wellesley, once the patient, has been treated, has been evaluated at a multidisciplinary clinic, we're bringing all of multidisciplinary care to Newton-Wellesley. We have a robotic surgery program there that's been there for a couple of years under Todd Francone, and urology is a big part of that. We've done more than 200 cases since we started that program. We've had 0 intraoperative complications and just 2 minor postoperative complications. A patient that went home with a drain because of a persistent urine leak, and that turned out fine. The other one was readmission for a small bowel obstruction in a patient who already had a pouch. So overall, we can consolidate all of our multidisciplinary care at this point at Newton-Wellesley, which is excellent for our Newton-Wellesley patients. These are the surgeons that are operating, myself and Doug Dahl, and also Adam Feldman and Anton Whitner does some reconstructive urology. So it's not just cancer, we also do some reconstructive surgery.
Thank you so much, Jimmy. So a lot of exciting stuff, a lot of new stuff. I want to make sure to leave time for questions, but just logistically, so okay, we told you about all this, what's actually in place now and where are things going? So myself, Dimmy, and then our radiation oncology colleagues, Dr. Tansky and Dr. Tillman, we do a GU multidisciplinary clinic here every second and fourth Thursday. So for example, today we're seeing 4 new patients in the clinic this afternoon. Referrals typically occur through the primary urologist. So Dr. Lamont, Dr. Long, Dr. Saltzman, Dr. Lazarus, whoever sees the patient and makes the diagnosis refers them. But we do get a lot of patient-driven referrals, and PCPs can also refer. So if your patient gets a diagnosis and they come to you as their longitudinal provider, I just want to make sure you guys have the information that you can refer them to our multidisciplinary clinic by messaging our nurse navigator, Marlene, or myself, and then we can get them scheduled, sort through their information. What we want to highlight is all new prostate cancer diagnoses should go through the multidisciplinary clinic in 2020. These are conversations that should be had in terms of active surveillance versus active treatment, and then them meeting the active treatment docs, either the radiation oncologist or the urologic oncologist, and having a comprehensive discussion. Sort of gone are the days of you get a diagnosis, you're just immediately in a surgeon's hands or immediately in a radiation hands. We really think about these as a trio, as a team, to get the patient the best care. And so that's what's in place now. And I think the really exciting things on the horizon is right now we have it twice a month, hoping that to get it weekly, on a weekly basis, just given the volume of patients that are increasing. This MRI fusion biopsy technology is coming to Newton-Wellesley. We are in the process of fundraising the funds for it, and also there's a commitment to get this technology here. And then with that technology, also an increased MGH urology presence and further growth of an already robust robotic urologic surgery at Newton-Wellesley. And so with that, I think we stopped right on time for questions. Thank you for your time, and we'll take any questions.
Thank you guys. Really great survey of screening and also the treatment options. And I always wondered how the MRI guided biopsy was done. So that's actually it was really interesting to see. I think we had one comment in the chat box, which was it would help to have an epic order for this multidisciplinary referral. In general, this is a good segue. I know I see Monique's on this call. We just revamped the epic referral order. Monique, you want to unmute yourself and talk a little bit about that? Because I do think the PCPs would be interested in that.
Sure. So there now is a referral order that can be placed centrally. Essentially, it's through the It's a MGH Cancer Center referral. I don't remember the number offhand, but when you search for it, the option is there for you to choose Newton-Wellesley as a location and the disease site. So I think previously there had been multiple referral orders in the system, and we've consolidated that just down to one. We're working on getting deleting those old referral orders so there's less confusion, but there's one singular referral order now. I'm happy to sort of send out to the group if you want the specific.
Yeah, I found it just by searching MGH Cancer Center, and then you can see that one there. So, and then Chrissy, I guess that would go to your navigator if someone clicked GU. Is that how it would flow in?
Yeah, it flows into the navigator, and then we get them scheduled by looking at the
Right.
chart, doing a chart review and figuring out priority of who needs to be seen when.
And so classically, if I'm in the clinic or I'm in my office and I feel a nodule or get a PSA that's out of whack, you would recommend we refer it to the urology colleagues here first and then have them refer to your multidisciplinary clinic. Is that
Yeah,
correct?
I
Because you want a diagnosis first,
I
right?
think the clinic is for people who have a diagnosis. And so the first step is getting the diagnosis. And so, yes, the pattern of obtaining the diagnosis is the same, but we want to make sure we're capturing them once they have a diagnosis so they understand all their
Right.
options.
I'm going to just take advantage and ask a question since there are no other questions. So I struggle a lot in my office with men who still want to get PSAs past 70 or who have had a father or a relative go through prostate cancer and want to start getting PSAs at age 26. So, I mean, how do you manage? I mean, what kind of advice would you give me for a guy who's 78 who wants to make sure his PSA hasn't gone from 2.5 to 4 and try to stop that train,
Great question.
Yeah, so it comes up. So the first thing I always say in that age group is life expectancy. That's sort of the, I really don't favor PSA screening in somebody who's got significant cardiovascular, with a decreased life expectancy where something else is really going to get them before this prostate cancer. So I look at life expectancy and then I look at the trend, if he's gotten no PSA for 10 years and this is your first one, then I would get one if sort of there hasn't been a trend. If he's healthy and demonstrated a trend of stable, low PSA, he's not on, the other thing is make sure he's not on finasteride, any of your alpha reductase inhibitors, those falsely decrease the PSA. And I hate to, use the buzzword informed decision making, but it really has to be, you lay it out for them and you say, John, I think your chances of prostate cancer are low. This is the limitations of PSA screening. And you really just have to, but I would highlight that even if we find this now with transperineal biopsies with MRI, I feel better about over screening because we're not over treating. So I would tend to err on the side of your patient wants it, they're asking for it, do it, because it's not going to lead to bad sequelae as in the past where we've over-treated and over-biopsied folks.
Yeah, completely agree on all accounts for that part. As far as the younger patients, the guidelines and extensive research has shown that we really should not be starting PSA checks before the age of 40. So in these high-risk populations or family history patients, I tell them 40 is when we can start looking, and you really shouldn't have to worry about this before that.
Yeah. Thanks.
John, this is Saray. I just want to commend Chrissy and Dimi for their great presentation, and also just say that, I think we're doing our best to give state-of-the-art urologic care here at Newton-Wellesley. And, it'll be somewhat of a stepwise process, bringing some of the elements into, I'd say, the best of care status. The hospital is investing a lot in some of these newer technologies, robotics, et cetera. So, but I think really the critical element here are, the PCPs being on board and really understanding that in this day and age, the patient should get multidisciplinary care for every case of prostate cancer. And if we don't provide it here to them, they'll go get it at the Farber or somewhere else. that actually will be more chaotic for them given sort of the size of some of those programs. And here we'll give them a lot more personal care. So I really would push for the PCPs to remain involved at every step, once the diagnosis is made, to push for the patients to be coming to multidisciplinary here, if at all possible.
Thanks, Saray. All right, so we'll come to the end. A couple of reminders. QACQAY was the code, QACQAY. Number 2, oh, thank you very much for that. Number 2 is, don't forget, we got grand rounds Wednesday mornings on Zoom as well. The upcoming grand rounds talk this week is going to be on thrombosis in COVID disease. Next week, we have our talk on shoulder on Thursday as well. And also, I want to remind folks on this call, Mondays at 5 p.m., we have our medical staff call where you can find out updates and changes in processes as we go through COVID, and we struggle and we continue to change our processes and try to adapt to this new world order. And on that, I will leave you. Have a nice weekend, and we'll see you all next week. Thanks again, and thanks to our speakers again for a wonderful talk.
Thank you.